approach to the malignant lesions of breast. I'm very glad that I heard the subsequent talks that will follow, because this will be like the mother of all lectures which will help you understand some of the later lectures. So this is what I was saying, that it's like the bride's veil. Sometimes it's so long that it gets carried away. So I'm glad that the lectures that follow will be the veil that carries you towards this understanding breast pathology. So a quick overview of when do you think of cancer in a breast mass? And it's clinically, when Dr. Garbitsi, he sees a hard lesion with involvement of skin and ulcer, and if he sees palpable axillary nodes, that's when we think of cancer. Mammographically, if you see architectural distortion, a serous mass with which is hard on elastography and calcification, then microcalcification, those are the things that make a radiologist suspect cancer. And histologically, what we see is an infiltrating lesion with atypia and features of malignancy. So unfortunately, breast is a very heterogeneous disease. When you talk of malignant, it means a whole lot of things. So before we go on to the diagnosis, we'll understand quickly what are the stains that we do in breast cancer. So two category of stains is what we do. One is the stains for myoepithelial markers. Now, if you see this image here, those flat cells are the myoepithelial cells which surround the luminal cells. Now, it has a nucleus and it also lays down this basal lamina. So when you do the stain for nucleus like a P63, you see staining like this with gaps within the staining. Now, I can't afford a gap, because even within the gap, if some slips up, then I won't be able to pick up invasion from the duct in such situation. So I do a stain for basal lamina, which is basically a smooth muscle heavy chain complex, which is like a line that follows all throughout. So that's the first group of markers. There are many markers, but I would recommend these two. Then we do we do cytokeratins. We do two types of cytokeratins. We do one keratin for myoepithelial cells, and we do one keratin for the luminal cells. So why do we do it? So luminal cells, as I said, we use 818, and for myoepithelials, generally we use 5/6, but CK14 is also as good. Now, why do you do this? Suppose if I have an intraductal epithelial proliferation, if I see a good healthy mixture of these two types of cells, that means there is not much of monotony happening, there is no clonality happening. So I'm talking about a benign lesion. So that's the principle of behind using these cytokeratins. Remember, absence of myoepithelial cells does not mean that there is cancer, because anything atypical results in loss of myoepithelial cells. So please remember that, and remember to use these two antibodies, P63 and smooth muscle heavy chain complex. So what is the spectrum of malignant lesions of the breast? So you have epithelial lesions, you have spindle cell lesions, and breast is a biphasic organ because of stroma as well as epithelial cells. So you get biphasic neoplasms as well. And breast is a site of metastasis from all sides of tumors. So we'll run through a spectrum of these lesions before we go ahead. So focus will be on the epithelial proliferations, because they are far by law most common, and then followed by others. So let's start with the intraductal epithelial proliferation. When do you start thinking of this as malignant? So I already showed you, this is the luminal cell, that's your myoepithelial cell. And if you see this cell over here, this proliferation over here, if the green are the myoepithelial cells and the blue are the luminal cells, then in this particular ductal proliferation, I see a healthy mix of cells. And if you remember what I said, this is not a clonal proliferation, so I called it hyperplasia. Now, over a period of time, all hyperplasias are soil of neoplasia. So what happens is that these blue cells acquire mutations, they kill the myoepithelial cells and they become dominant. And this is when we call it as atypical ductal hyperplasia. Now, atypical hyperplasia, as I said, there's already mutations. So it's already cancer, but if it is in a large amount, we call it cancer. So only when ADH is more than 2 ducts, we call it DCIS, and that's DCIS for you. When it is clonal, the myoepithelial cells also reduce in the background, and some of the DCIS, and I'll tell you a little while, that they have capacity to invade and produce invasive carcinomas. Mind you, not all DCIS invade. So then we go to the next thing, and that is how do we make about distinguishing these things. Now, usual ductal hyperplasia is very haphazard. So if you see any intraepithelial proliferation that is haphazard, that's your usual ductal hyperplasia. Look at this image. What do you see? You see a mass of cells. Actually, when the duct gets irritated, the mass of cells that first goes into the center is the myoepithelial cells, and then the luminal cells enter at the periphery. So this is usual ductal hyperplasia. What will I do? I'll do a myoepithelial keratin like CK14, and if it predominates, I'm very happy. It's benign. I leave it alone. In atypical ductal hyperplasia, I start seeing atypia in the nuclei, and this little haphazard proliferation now becomes organized. The word organization means polarization of cells. You can see in the right side image that with around the lumen, the cells start oriented around the lumen. That's polarization in intraductal hyperplasias. So you will get, if you get a lesion, intraductal proliferation, where you have some slit-like places, some polarized places, some atypia, and you don't want to call it DCIS. That's, we pathologists are very smart. We always use these entities so that we can park ourselves in between two common lesions. So this is the in-between go. And if I do myoepithelial marker, it will be very sketchy or absent in these lesions. And in DCIS, there is an organized process. So there's monotonous process. It is very uniform. So it's very easy on HNE actually. And if at all I require, all I do is to check that within this proliferation, there is no myoepithelial cell. And that's why the CK14 or 5-6 will be negative. Now, just as, in the breast, there are ducts and there are lobules. So just as the DCIS is happening in the intraductal regions, in the lobules, there is another spectrum that is happening, and that is the columnar region of lobules. Actually, this is the first pre-neoplastic lesion in the breast. What you get is the acini being converted into these apical snouting kind of structures. Unfortunately, these are very commonly detected on radiology, and these are the cause of false positive mammographic pictures. Again, when you have an alteration, very quickly it becomes hyperplastic. So this is columnar cell hyperplasia, and it's not within time with mutations accumulating, it becomes something atypical. Now this does not have the architecture, it's not a duct. So what do I call this? So I call it flat epithelial atypia. So this is atypia. There is no architectural distortion, but there is atypia, there's mitosis, there might even be punctate necrosis. So that is where I call it, instead of, I can't call it DCIs because it's occurring in the lobules, so I call it flat epithelial atypia. So that's the spectrum of intraductal epithelial proliferations for you. Now, though on picture it looks very beautiful, sometimes we use IHC to kind of help us. The first IHC uses ER. If ER is intense in any lesion, you are dealing with a malignancy. If BCL2 and cyclin D1 are also intense, you are dealing with a malignancy. If you are having reduced expression of the luminal, increased expression of luminal type of cytokeratin and loss of E-cadherin, you are again dealing with malignancy because that's usually a lobular. And similarly, you can use the luminal type of the myoepithelial cytokeratins also as a base. Now, it's very interesting that in CK56 is not seen in the low-grade DCIs, but in the high-grade DCIs, sometimes the neoplastic cells express 5-6, so you should be aware of it. Now, let's look at this lesion. Please feel free to join in, but I think I'll just go through some of these on my own and then we'll chip in. Now, if you see this lesion, this is a mammographically wired localized lesion. I see a group of ducts. And what do I see? Do you think it's haphazard or this is uniform? Anybody? I can't see you, so anybody can just drop in the thing. Do you think this is organized or not organized? Anybody? Nobody? Okay, so if there are no takers, then I think this is haphazard. Okay, everybody agrees it's haphazard? One yes.
Yes, ma'am.
Yes, ma'am.
Yeah, it's haphazard. And what is exactly what happens? Now, it's very beautiful what you see in this image. That there is a myoepithelial cell, that there is a myoepithelial, and see how it's creeping inside. So technically, I don't need IHC because I know this is haphazard, I will call it. But then, life, you have to convince others that you are right. You always know you are right. So then you do a myoepithelial cytokeratin, and you see this is what is called a mosaic pattern. That means a good admixture of luminal and myoepithelial cells, and this indeed is a usual ductal hyperplasia. Now, this on the other hand is a core biopsy from a lady who was on follow-up. They found microcal. They did actually a WAB biopsy, and when you see this, what do you see? You see obviously intraductal proliferation. Now there is atypia. And again, you see maybe two types of cells. The lining cells are a little columnar, and what is in the center is a little smaller. So you're thinking, okay, but this lower duct is what is important. What do you see? You see organization. You see what we call as, fancy words used by older pathologists as Roman bars, trabecular bridges, all kinds of fancy terms. So you see a bridge. You see a bridge between the lumen and the cells are oriented towards the lumen. So I know this is not, see this one above also, you see, there's a bridging. And when I see this orientation, then I get worried. So I do what marker? Anybody? Which marker do we do? Which marker? Nobody? Somebody has to tell me. What marker did I show you some while back?
Some CK.
CK56. Perfect. So I do my epithelial marker, and you can see that none of the intraepithelial cells have it. Now, this is atypical. You have architectural atypia, and you also have loss of myepithelial cytokeratins. This is an SMHC, by the way, which is almost similar to the CK56. And now I know, see this duct, it's even more worse looking because the myepithelial cells around this is reduced remarkably. So I am looking, this is trouble. So now what I do, I saw just a little focus. This is a mammographically guided lesion, mammographically detected lesion. So I said, yes, this is atypical, but you need to excise this because I don't know. See, remember what I said? 2 ducts is ADH, more 3 ducts and more, I called it DCIS. So before calling it DCIS, I need to know the whole area in which it was. And lo and behold, when the final excision came, it was a radial scar. So then this ADH remained ADH, it did not become DCIS. So moral of the story is, ADH is DCIS. It's the quantification that changes, and that's why you have to be very watchful. So ductal carcinoma in the frank, where we don't argue, is a non-obligate precursor of invasive breast cancer, and most women end up with invasive carcinoma diagnosis in 2% of the cases after invasive. Now, please remember, this is Western data. This is screen-detected breast cancer data, and I don't think this is applicable for India, but nevertheless, we have to, since we don't have Indian data, this is what we quote. The difference in DCIS in the non-screen population and screen population is, what do we get? We get palpable DCIS. Whereas what do they get? They get screen-detected DCIS, which are microcal. Now, something that is not palpable, that means the volume is not enough. It's screen-detected. So clearly, it's slow-growing. Whereas what do we get? We get palpable, and that's a totally different story. So there are several prognostic factors like size, margin, radiation, grade, etc. Now, as pathologists, what we need to do first is grade DCIS. There are many systems in place, but the one that hit the bill was this one niece classification, because it's very simple. You know what, my students write very funny classifications of DCIs when they come to my room, and I always tell them, understand what is clinically relevant. So what is clinically relevant? Surgeons like Garvita are looking for, is it high grade or not? So if it's high grade, then you have to say whether it's, that's the thing. If it's non-high grade, then does it have necrosis or not? So the one which is most important is high grade. And this has been woven by this is the one niece classification, and it has been woven into a prognostic index, because mind you, in Western countries, the DCIS is very, very small, and they are detected on mammographic screening. So the dilemma is, what do we do with it? So this is prognostic system that is detected to find out whether I have excised that lump, which is DCIS. Now, what more do I do? So commonest thing is to give radiation. So do I give radiation or not? If it is low grade, well excised, if it's low grade, well excised DCIS in an older patient, we don't do anything. We don't give radiation. That's the low risk try. Whereas if it's a high grade, we straight away give radiation. And in fact, even a mastectomy, if this goes beyond 10 and more as per this table, and you can read it. But most of the times we don't have this kind of luxury. We have to diagnose it on core biopsy. So then this is the system that we use. Just as we use for invasive breast carcinoma, there's a grading system as low, intermediate, and high in DCIs, and that depends on nuclear size. If the nucleus is 1.5 to 1 to 1.5, the size of a normal red blood cell or a lymphocyte, it's high. If it is greater than 2.5 times the size of the red cell, pleomorphism is present. Chromatin is coarse in the high grade, where it is fine in the low grade, and nucleoli are absent in the low grade. They are present in the high grade. Mitosis clearly is plenty in high grade, and necrosis is the trump card, because if you find necrosis and you're struggling between intermediate and high, you have to call it high grade DCIS. So problem is, what's wrong with this grading system? Clearly, what we have done is we have created, actually there should be only 2 groups: clinically actionable DCIS and something that you can observe. So the low risk trial, I've deleted some of the slides, but The LORIS trial, LOIRS, that trial is exactly looking at this question. The preliminary results are out, and they said, yes, you can do a binary classification of DCIS. You don't have to have intermediate. You club the low grade and intermediate together and separate out the high grade. And that's the future, I think, which will happen soon. So this is low grade DCIS. This came as a mammographically detected mass. Actually, this patient came with nipple discharge. And you can see very low grade DCIS, nothing worrisome, very abundance of myepithelial cell. Now, invasion does not occur in low-grade DCIS because the tumor itself is low-grade. It does not have capacity to produce invasive tumor. So what does it do is basically you may get invasive low-grade DCIS because it's a field phenomena. Just as this DCIS is developing, somewhere else an invasive carcinoma is developing. And that's why you get low-grade on its own does not invade. Whereas high-grade palpable DCIS, totally different story. Dr. Garvit will vouch for it later on in the slide seminar, that these are a nightmare for any surgeon or oncologist to treat. What happens is, there is a very interesting thing. Now, DCIS is like a racemose system. There is enough space between the ducts. So technically, these should be not palpable because it's within the ductal system. But why the hell is a tumor producing such palpable masses where the ducts are fused? So this is the concept of neoductagenesis. That means this tumor is smart. What one duct does is it secretes cytokines that will produce more ducts. And that's why it forms this conglomerate of dust. And an old paper in 2000 has shown that when you have this type of tumors, they do have 10% incidence of recurrence. And that is the worry in palpable DCIs. That though 90% will do well, the 10% will die of metastasis. So that's the worry. You tell the patient that you have a very good disease. And after that, if she gets a recurrence, then she's going to catch your throat. And that's the problem. So this is the story. My dear friends, high-grade comedo DCIS is a Rottweiler which has been caged. You do something with the cage and it's all out and it kills. So remember that. And that's unfortunately our Indian problem because we don't have screen-detected cancer. So when there is invasion in DCIS, it's often very frank. I don't need IHC to detect. But when I have lesions like this, where, I don't know whether this is going into a TDLU or whether this is frank invasion. In this case, I need myepithelial markers, which will show me that here in this wall, there is a break of the basal lamina and the cells are coming out. And that's the reason we use myepithelial markers only in these lesions. When you don't see these changes, don't ask for myepithelial cells. So this is what will happen. You see, this is a SMHC, and you can see the nice break in this particular DCIs. You can see a gap here, and you can see nicely the invasive tumor is coming out. It does not have any lumina. And the same thing is seen in P40. You can see the tumor. Sometimes it becomes very difficult because the myepithelial cells are missing in these lesions to pick up the invasive exactly. Now, from the DCIS, we move to invasive carcinoma. Now, what is our concept of invasive carcinoma? Infiltrating, atypical, and malignant, capable of killing. So that's your thing. Now, imagine if I have a breast cancer, which is, imagine this image. What you're saying, you see a garden full of flowers. You like them, but you don't know what the hell to do with it because you are not aware of any type particular. If beyond this, if I so this is IBC NST. What if I tell you, okay, some of these flowers are very unique. They have this unique behavior. We can manipulate their disease progress by changing the treatment. This is how it will look. And this is such a beautiful picture. So these are the special types of breast cancer, and pathologists are blonde spitless. So obviously we keep doing that. This is the WHO classification of several types. Now we classify breast cancer based on pattern of growth. So tubular is the natural. A breast is a racemose structure. So tubular pattern is natural. Any tumor that is tubular is a very differentiated tubular. So it's good diagnosis. Then what happens? Unfortunately, cancer cells are smart. They acquire mutations. So if you have E-cadherin or CDH mutations, then what they'll do is they'll start falling off like they're nobody's friends. And then you get these lines and cords and Indian files and what have you. On the other hand, if you have a PIK3 mutation, then remember this blue cell, what if it swips? Instead of this is your line and that's it, turn this cell out. It becomes a papillary lesion like this. So papillary tumors have PIK3 mutations. They often produce the reverse polarity. It's something I'm very passionate about, so I'm not going to talk about it. So this is what happens. Another mutation, and again, reverse polarity. So instead of facing the lumen, this cell fits and it starts facing the stroma. So what will happen is it will secrete the enzyme that it normally secretes into the lumen, into the stroma, and you get these gaps around these structures. And this is what we call as a micropapillary pattern. And subsequently, I'll tell you that you add more mutations and it becomes a mucinous carcinoma. That's a story for later. So patterns are fine. So sometimes cancer cells are even smarter. They express mesenchymal markers. So that's what we call as epithelial mesenchymal transition, and that's where metaplastic carcinoma comes in. So to avoid, so what is the importance? So you have a good, bad, and ugly. The good prognostic one, we can avoid chemotherapy. We can limit your axillary dissection because axillary dissections cause a lot of morbidity in breast cancer. So we can do a sentinel node and we can totally tell the patient that she's going to survive 10 years. Whereas the bad are the ones where we don't know. We know they're going to come back in 5 years, but they have reasonable survival. And the ugly are where we don't know what to do. And most of the triple negative breast cancers fall into this category. And please understand that when I say special unique type, what I mean is the unique type where the unique definition is followed. If you use a liberal definition, then the whole prognostic impact is gone. I'll tell you about mucinous carcinomas a little later. For example, if you have a grade 2 tubular carcinoma with greater than 90% of tubules, no patient ever dies. Whereas if it becomes less than between 70 to 90, then the prognosis falls down a little bit. So remember to use strict definitions when you are typing special types of cancer, and we'll quickly run through the full spectrum of it. So this was a wire localized lesion because the woman had mammographic screening and she had a small lesion typically seen in differentiated cancer. So there are many studies that show that well-differentiated DCIS and well-differentiated breast cancer never kill. In our zealousness to find the hard ones, the high-grade ones, we kind of managed to find these ones also. So in India, very uncommon. Only in the rich population which goes for mammographic screening, we get this kind of tumors. So this is what very nice tubules, uniform tubules, 100% tubular tumor, very strong ER. This is your tubular carcinoma. And as I said, very few patients die. Very few patients have lymph node metastasis. In fact, I remember I got a call for a tubular carcinoma with a clavicular lytic lesion. And I told Dr. Sarin and me both said that, no, this cannot be metastasis. It has to be some different disease. And it turned out to be a plasmacytoma. So remember that this is the reason we need to know. Now, another lady. Now, this lady is actually a mammographic screen detected lesion. Now, her core biopsy is a core biopsy. Remember, I'll show you a lot of cores because that is the mode of diagnosis of malignant lesions in the breast today. So you see that this is a core biopsy, and you can see actually it was called inflammatory, and you will understand why, because yes, these look like lymphocytes, don't they? So what is the clue here? Anybody wants to say? Anybody is seeing something different? Of course, this is a lecture, so obviously I'll show you, put up the best pictures. So you see there are intracytoplasmic inclusions, and that's the clue that it may be a very low-grade disease, but this is invasive infiltrating carcinoma with cadherin mutations because they're falling apart like this. So what will we do? So that's here, it's better seen in this picture. You see very tiny cells, so tiny that they're mixed. So this was actually a radiologist, Seema Mehdi's case. And she said, madam, there is this patient, I'm very sure it's cancer, but outside it has been reported as negative. And the moment I told her it's lobular, she said, yes, that's the only disease that can look like this. So we did a cytokeratin, you can say nicely cytokeratin positive, and ER strongly positive, E-cadherin negative. So what are the stains that we do for lobular carcinomas? Clearly, we do E-cadherin. Now, what is this E-cadherin? E-cadherin is a surface membrane protein that is anchored to the beta-catenin, and it's like a scaffold on which the breast cancer assumes its structure. If you have mutation in E-cadherin, what happens is it falls into the cytoplasm and it is lost. It is removed by the cell. So that's why we see loss of E-cadherin in lobular carcinomas, and that's exactly the story that you see. This is a normal epithelium, and this is an E-cadherin protein, and this is the loss that you see. Now, sometimes in 10% of lobular carcinomas, you don't see E-cadherin loss. Remember, it may show you a cytoplasmic dot-like staining, which is also a loss of E-cadherin, and that you must understand. So then we do beta-catenin because that's another reason, that's another protein that is lost in I told you it's anchored to the E-cadherin and beta-cadherin, and that's why. And the final thing is a cocktail of P120, E-cadherin, beta-cadherin. So they are like friends which are together. One of them mutates and all others fall apart. So that's the kind of story with lobular cancer. So invasive lobular, why do we need to know about it? Importance is very difficult to diagnose on radiology as well as clinical sometimes. And it shows germline CDH mutation. So these women have to be screened because they're also prone for gastric cancers. And they're typically low grade. And if you have a high grade ILC, then we call it something else. And it is as bad as invasive ductal carcinoma. And there are several studies to say so. Now here is a tumor. What kind of a pattern? Anybody wants to tell me what kind of a pattern is there here? No? Anybody? Yes, please tell. I can't see you because that's the WebEx platform. So that's great, right? I don't know who I'm asking questions. Who's answering? So you see, this looks like the alveolar pattern, right? You have
Ma'am,
small.
sorry. Ma'am,
Yes.
sorry to interrupt you, ma'am. Actually, someone is asking to use the laser pointer. Actually, this white arrow
Okay.
is not visible.
Okay. Stop sharing. Escape. And share. 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 Where is the laser pointer? Actually, she helped me last time, but I can't seem to find the
Yes, ma'am. Yes, yes.
pointer options. Yeah. Can you see this now better?
Yes. Yes, ma'am. Yes.
Yeah. I'm sorry,
ma'am.
you should have told me a little earlier. Okay. Great enough. Better late than never. So you see there are little small nests. Now these are not big nests. So these are actually alveoli. You can see one small cord and then the little lobules. Okay. So this is the alveolar variant of lobular carcinoma, and you can see that there is dot-like E-cadherin here instead of the total loss. This is a tubular lobular carcinoma. You see tubules, but it has lobular features. Now it has very good prognosis, but the problem with this is E-cadherin positive tumor. Here is another lobular carcinoma, but this time you have a nuclear grade which is higher. You see the same pattern of infiltration, and you see that the nuclear grade is grade 3. So when you see a nuclear grade 3, and of course it's E-cadherin loss, we call it a pleomorphic lobular cancer. It typically occurs older women. There's marked cellular atypia. Sometimes they may be, because normal lobulars are ERPR strongly positive. These guys may be even HER2 positive, and they have high incidence. They behave as same as IDC of the same grade. And that is why it's important to know whether it's pleomorphic or not. And it carries unique, some similarities with IDC and some similarities with lobular carcinoma, which is expected. So there is the spectrum of malignant papillary lesions. Okay. So you have, since I'm talking about malignant, you have the in situ and the invasive ones. Now papillary tumors are beautiful because by and large, they're better prognosis. So these I'm not going to discuss. The two papillary lesions that actually are called in situ carcinomas in spite of not having myepithelial cells is encapsulated papillary and solid papillary, intraductal type, and we'll look at it. Whereas there is in solid papillary, there's an intraductal variant and invasive. Sometimes I think, tumors play trick with us. Imagine the same tumor is intraductal and then it becomes invasive. That's the fascination of breast pathology. And of course, you have invasive papillary carcinoma NOS. So let's try to understand what the heck is happening here. So this is a papillum. Please pardon my images. You can see there is a core of vessel and a nice lining epithelium. That's a papilloma for you. But papillomas don't resist. They're the restless creatures. So what happens is the myepithelial cells proliferate, start making them looking more solid, very atypical. And you enter with mutations, you enter with DCIS, and that's the spectrum. Now, so let's look at the spectrum malignant. We'll leave out the benign here. We'll look at malignant. So there are two variants. Now, this is a typical papilloma with whatever, atypia, DCIS, which becomes malignant. So, but you have myepithelial cells not only at the periphery of the cyst wall, because papillary tumors are cysts, they occur within ducts, but you'll also have it at the base of each papillae. On the other hand, there is one cancer which is a papillary tumor, which is within a cyst, but there is no cyst wall. It's not really a duct, it's a pseudocyst. Okay. And so it will mimic a papilloma because it will show it as a cyst on every radiology. Now, in this, if you look at it, what you see is you do not see myepithelial cells either in the cyst wall or in the core of the papillae. So that's your encapsulated papillary carcinoma. The third variety is a papillary carcinoma that looks like DCIS, and you will really miss it as DCIS unless you do myepithelial cells, and you will realize that there are no myepithelial cells within the entire lesion. So let's look at a couple of cases. Now, some of these you are new to you, some of these may be the odor. So you see there's a huge cyst. You can see nicely cyst. You can see it's connected somewhere to the central quadrant of the nipple areola there. And you see, you can't find a duct wall. It's a cystic structure, but you can't find a duct wall. You look at the adjacent breast, you see DCI, so you're very happy, okay, I mean, and there's some malignancy here. And when you look, you see these papillae, there is no myepithelial cells. You see this very atypical, mitotically active papillae. So, you know, it's a papillary carcinoma, but it's in a cyst wall. And that's why you'll do first, of course, the myepithelial markers, and you'll see they're absent within the lesion, but they're plenty in the DCIS, which is next to the tumor, as you can see here. So, you know, this is papillary tumor within a cyst. So we call it encysted or encapsulated papillary carcinoma. It's treated like DCIS because it has fantastic prognosis, okay? And because it's a luminal cancer, it has strong ERPR, so you can, you know, kind of treat this patient with tamoxifen, predominant anti-hormones predominantly, and grade is the most important factor. Now, this is another tumor. This was the main part of the tumor is encapsulated papillary, but what you see is, you see an invasive carcinoma coming out from it. Now that's trouble, right? Because what is encapsulated papillary? You treat it like DCIs, you treat it like in situ. And here is a invasive. Now what do I do? Now remember, this is your focus of interest. This is where everybody will treat the patient like. And this is where you treat it like DCIS, okay? So invasion is defined as presence of clusters which are greater than 10 millimeter beyond capsule. And, but in spite of that, you have to, the incidence of invasion is around 12 to 30%. Some studies report higher percent. In spite of being invasive, they have very infrequent lymph node metastasis and very infrequent distant metastasis. What we have found is that this invasive VPC, they lie between frank IB and IBC. So that's the story of invasive. This is our own study, which Aarti, my student, did. We had around, now we have 135 cases, but you can see that only invasive cancers ever had an indent, and none of these patients really died. So, moral of the story is that very few of these will die. So, this is good diagnosis to give. Now, what does this look like? 75-year-old with a 6 centimeter breast lump. Anybody? DCIS or invasive? Anybody? No? Okay. So, it does look like DCIS, doesn't it? That means you didn't listen to my earlier lecture. Okay. So it looks like DCIS, but again, something funny, right? It's papillary. You can see papillary. And in the higher part, what do you see? You see that the papillae are fused. That means if you have a papillary and if my gaps are filled, then I will only see cores of the vessel. So that's what I'm seeing. I'm only seeing a core of a vessel here. So this is solid. This is papillary. So you know the diagnosis. It's solid papillary carcinoma. All I have to do is do P63 show and SMSH to show that there are no myepithelial in this lesion. I call it solid papillary intraductal variant. And of course, one of the trick thing is this is very strongly ER positive and it shows chromogranin staining as well. So solid papillary carcinoma is defined by solid papillary growth pattern, absence of very few myepithelial cells, neuroendocrine differentiation, and seen in usually elderly women more than 70, though in India, I see even young women with this cancer. Because remember, when you talk about age, it's a biological age also that has to be considered. Anyway, so this is your intraductal variant, but life is never same. What did you see in encapsulated? You saw encapsulated and streaks coming out. Same thing happens here because basically understand that they don't have myepithelial layers. So streaks coming out now make it invasive. So how will you treat it? Based on the streaks coming out. Unfortunately, the streak, or fortunately for the patient, the streaks coming out of the islands of tumor cells coming out of this intraductal growth, they produce mucin. So what happens? Number one, you get invasive, like here. And number two is they get mucinous. Now, this is what Kerner way back in 2002 said that mucinous type B is actually solid papillary carcinoma with mucin. So that means mucin is a secondary event in breast cancer. And this is what I have been saying for the last 25 years. But yeah, I still have to make the statement. So now I come to something that I'm very passionate. So what I was doing 25 years ago, or 26 years ago now, that I was looking at papillary tumors and I was looking at mucinous tumors. And suddenly I realized that mucinous carcinomas in India were not doing well. We had patients who were coming with distant metastasis. And our surgeons were telling me, don't worry, Maji, aapko acha cancer hai, aap theek ho jaoge. And I see them dying in front of me, and I was wondering why the hell is happening. The next thing was that I was looking at papillary, and I realized that there is, so this was the pattern that intrigued me, and that is what I showed you is the micropapillary pattern. And then it struck me that this micropapillary pattern is exactly the same pattern as invasive micropapillary carcinoma, which is a very bad tumor. What is the difference between the two? The difference is mucin. So if I add mucin to this tumor, it becomes mucinous type A, because remember what Kerner said, mucinous type B was solid papillary carcinoma. So the whole picture had to come together. And this is the first paper I wrote. Actually, I did the study in 2000, but I published it in 2008. And you see that the micropapillary pattern produced a very high incidence of metastasis. And some of these micropapillary carcinomas, they recurred. The pure micropapillary did not recur as mucinous, but the mucinous recurred as micropapillary ones very easily. You can see around this, I think around 20, 30 patients recurred as micropapillary. And when they recurred as micropapillary non-mucinous variants, they died of the disease. So everybody in Tata Hospital knows micropapillary in Dr. Tanuja. So I won't waste much of your time. What I did, I want to put forward a theory which I've been working on for 26 years, that reverse polarity neuroendocrine differentiation produces mucin. So mucinous carcinoma is not. So I never report mucinous carcinoma. I call it invasive micropapillary with mucin, solid papillary with mucin. That's the way I report it. And I think now we have enough evidence to say so. And so these are some of the references in case anybody of you wants to read. And Mamta, my PhD student, is working on this. We have created a mouse model where we are actually showing the change in this pattern, and I hope we are close to confirming my hypothesis before I retire. Now here is a 74-year-old lady, and you see a mass, right? You see a mass, but again it starts looking like DCIS. You go on the higher power, again it looks like DCIS. And when you see carefully, you see that this is a weird DCIS because the cells are oriented. There is a group of cells which are tall, and they are oriented, very apocrine looking, and they are oriented towards the stroma. So there is reverse polarity. More of this reverse polarity, you can see every cell is oriented towards the stroma rather than the lumen. You can see everything is oriented around the vessels, if I may say so. So apocrine, reverse polarity, looking like papillary carcinoma thyroid, or cell papillary carcinoma thyroid. So that's how it looks. We do the myopithelial markers, they are negative. So you know it's invasive, but it's a specific type. You do an IDH2 mutation and it comes strongly positive. So what is this? This is what is called as solid. Now it's called as tall cell carcinoma with IDH mutation with reverse polarity. The important part it mimics DCIS. No problem because they behave exceptionally well. They're triple negative. So the importance is recognizing this is a well-behaving cancer because you will end up calling it a TNBC like this patient did. And actually, you don't have to give them any chemotherapy. Only one patient has ever got metastasis in literature. There are some recent reports about bad behavior. But as I said, if you use strict definition, the bad things don't happen. But if you use liberal definition, all of us are eager to make case reports, right? So when in the eagerness of case reports, we end up diagnosing things wrong. And then is the Trump, Donald Trump in breast pathology. And these are the neuroendocrine tumors. Why do I call them Donald Trump? Because they keep changing their statements. And we don't know. And the culprit is the WHO. Because they change the statement, we have to make the change. I already told you three things are linked. What are linked? Papillary, mucinous, and neuroendocrine. So this everybody recognizes, but why have an entity when you know that these are linked? But that's the splitters for you. And the neuroendocrine classification has been changing and has become actually bad. We were very good in 2003. We were because the pathologists were that time very, very different. They're very philosophical. Whereas today, what do we have? We have two types of breast cancers with neuroendocrine differentiation. The IBCs with neuroendocrine differentiation like SPPC and mucinous are not included in the spectrum. You call it neuroendocrine tumor if it's a very low-grade tumor with 90% of neuroendocrine differentiation. You call it a carcinoma if it's high grade and it shows greater than 90% neuroendocrine differentiation. If you don't have neuroendocrine differentiation, if you think it's an NET, you call it mixed NET IBC. And if it has less than 10% neuroendocrine differentiation, you call it IBC. That's the kind of thing that the WHO has created for us. Now let's look at these studies. Now I'm not going to go into this table. Alpana, my student, has made this table for me. So 4 latest study, this particular guy from Memorial, he said that if you should use the Nottingham grade to classify these NETs, or neuroendocrine tumors of the breast, because that defines the prognosis better. So what does it tell you? It tells you that most of these NETs are in fact of breast origin, and that's why strong belief. Zong et al. Said that in some only is very common. Personally, I think more than one neuroendocrine markers should be present to call it as neuroendocrine. But as in we are pathologists, we all have all philosophies, and we put them in publications. So unfortunately, we have to read it. So why et al. Said that, okay, NET have slightly different mutations than IBC NST, but if you see the mutations, they're exactly like solid papillary carcinoma. So I am still confused as to whether I will call them NETs. I very rarely call anything NET unless somebody pushes me to the wall. And I have a strong concept that neuroendocrine hyperplasias of breast occur. So to me, all this paper are actually misleading. And this is my philosophy. Take it with a bucket full of salt. So I think NETs arise from divergent differentiation of stem cells, either in epithelial cells, and I have seen UDH with neuroendocrine differentiation. And so there is no clear guideline. We and Tata definitely treat it like, so if I see, most of us, thankfully, we are not a screen detected population. So whatever carcinoma I see neuroendocrine differentiation, I still end up calling it invasive ductal or breast carcinoma. So that's my take on it. Now let's look at another elderly woman. So interestingly, all these special types occur in older women. So this is a 65-year-old lady with a breast mass. Now this is something that all of you will recognize. Does it resemble anything in head and neck? Anybody? No? You see this blue colored material. So adenoid cystic carcinoma of salivary gland. And you see it better here. You will never see a very pretty picture because that's not the case with breast adenoid cystic carcinomas. And when you do epithelial and myopithelial cytokeratins, and you can see that there is, if you do a luminal cytokeratin, this is CK7, which is nicely positive, and the surrounding cells. So this biphasic pattern is very important to have to report on adenoid cystic carcinoma of the breast. So it affects postmenopausal women in the age of 60 years, and it's very important to have the biphasic pattern. Now, there is no literature about if I don't have biphasic, should I still call it adenoid cystic? Absolutely chaos. Thankfully, in Tata, we are 4 or 5 pathologists doing breast cancer. So between the 4 of us, we take a consensus and we give the diagnosis. Now, MYB-NIF fusion occurs in the salivary glands, but in the breast, it's very uncommon. Again, I told you, remember that pure and not pure. So the pure ones always carry the MIB rearrangement, but the impures like solid papillary do not carry. Solid adenoid cystic do not carry. So what are the states that you will do to pick up something? C-kit is very popular, but remember, C-kit is not it's a very ubiquitous marker. So you have to make sure that this is a salivary gland and not a breast cancer. We do androgen receptor because it's negative in adenoid cystic carcinoma. We do T53 because it is positive in triple negatives, which look like adenoid cystic, and MIB protein if you do have that IHC. And remember, adenoid cystic always has a low MIB1. So remember, what's the importance of identifying adenoid cystic carcinoma of breast? Remember, it is insensitive to chemotherapy. So you'll only give radiation and send the patient home, and that's a huge relief for that particular patient. This is a solid variant, very, very difficult to diagnose this. And this is the cause of confusion because many of them actually are triple negative breast cancer. So I don't diagnose this unless I'm pushed to the wall. Another older lady, this time with something resembling thyroid, multiple cysts, inspecific secretions, and some papillary structures with intracytoplasmic mucin, and a very beautiful PAS positive mucin. So it's secreting something. So it's secretory carcinoma, again a very good disease. Usually it is characterized by the ETV6 NTRK fusion. It has good prognosis, but only when it is seen in younger patients. In older patients and in men, it has aggressive behavior. It is a triple negative breast cancer by and large. Now, this is years back. I had written this paper that MUC4 protein is the translation of ETV NTRK fusion in these patients, and that's why we said that you should look at MUC4 as a diagnostic marker if you don't have NTRK in these patients. So NTRK is very important because you have larotrectinib, which is a targeted drug against NTRK gene fusion. And if you have a triple negative breast cancer and which you think is secretory, I always do this. I always look for security, and if I find it, I write the patient gets benefit of this drug, provided she's rich, because there's no poor patient can afford this drug. Now we come to a different genre of tumor. Now these tumors, we are talking about epithelial. Now they are moving. These are carcinomas that are showing you chondrite differentiation. You can see this is all chondrosarcoma, but you know it's in the breast, so you have to call it metaplastic carcinoma because it's an epithelial tumor that is now producing stroma. This is another metaplasia. That was a stromal metaplasia. This is an epithelial to epithelial metaplasia, and this is a squamous carcinoma arising in the breast. You call it as an invasive metaplasia with squamous differentiation. So this is a Pandora's box. So unfortunately, this is one disease with so many sub-entities that it's not one disease at all. It's a different genre. So you have low-grade adenosarcomas, you have fibromatosis, you have squamous spindle cell, osteosarcoma, chondrosarcoma, everything being added up there. And what they said is the squamous carcinomas is the most worst behaving amongst all of these metaplastic carcinomas. Okay. So what about the IBC NSTs? So invasive breast carcinoma NST, this is what all of us regularly handle. The most important thing is what stage they are. If they're operable, we do surgery, we do sentinel node because we don't want to torture them with an axillary node dissection. We then do chemotherapy based on stage and biomarkers. And if it's locally advanced, then we give chemotherapy because what we want to do is we want to shrink the tumor into an operable size. It does not benefit the overall survival, but it helps to make an inoperable tumor operable. The chemotherapy is decided on biomarkers, and then you follow it by surgery, radiation, SOS. So the first thing that the Nottingham guys did, which was a path-breaking thing, and that was grading breast cancer based on the tubular differentiation. All the other parts of that grading, TNM grading, were already invented. It's the tubule that the Nottingham guys added, and that caused a remarkable improvement. All well-differentiated grade 1 to grade 2 cancers have more than 80% survival, provided they are operable. And of course, ERPR was the next game changer, where 30% decrease in mortality has come with just giving anti-hormonal therapy to these patients, and that's a very important thing. And HER2, I'm not going to go into the details because I have many more things to do, and I've already finished 50 minutes of my time. This is just to tell you that IBC NST is no longer, if I'm a molecular pathologist, I'm not interested in my histology. I do this metaplastic study and divide the IBC into 10 clusters. And it doesn't matter because you can see the integrative cluster 3 actually has tubular carcinomas, lobular carcinomas, the medullary is in 10. So I am only classifying genetically. I'm not looking at histology, and that's what happens if you progress in the world. Now, this is a 45-year-old lady, breast biopsy. Now, this came, one of my residents was showing, and he said, okay, invasive micropapillary. I said, hold on. Now, there's one feature which I always worry. You see, there is this breast, and you can see that the tumor is actually going into the breast globules. This does not happen in normal breast cancer. If it invades, it destroys the lobular cell pass. And you see, all of the tumor is in LVI form. So the first history asks is there a primary lesion elsewhere? My resident told me, no, madam, this is breast primary solitary breast mass. No chance this is metastasis. So I said, fair enough. And ERPR came negative. Now, in a papillary tumor, I'm not expecting that ERPR to be negative. So I insisted on opening the electronic medical report myself. And the GATA3 I added, and it was negative. And PAC8 was positive. This was patient had an ovarian mass, but you know what happens when you're doing investigation for breast, you see the breast mass and subsequently patient comes back with an ultrasound abdominal, CT thorax, and it actually was a breast metastasis from serous papillary carcinoma ovary. So what are the breast specific markers? GATA3, TRPS1 or TRPS1, and SOX10 some people believe, and mammoglobin we don't use anymore nowadays. So the best mark is if you are doing with a luminal cancer, use GATA3. If you are using with a triple negative or a HR hormone negative cancer, use TRPS1. We come to the other part of the story. You have this actually came to me like lobular cancer, and yes, vague lump, everything is fine. It does look like lobular, right? Now the trick was that I started seeing these cells. What are these cells? Anybody? They are eosinophils. So when you see eosinophils, you know something looking like a lobular. You know one tumor you have to rule out, and that is, this is LCA positive, CD68 MPO positive. This was a granulocytic sarcoma of breast, and breast is a very important site of granulocytic sarcoma, and the bone marrow did turn out to be acute myeloid leukemia. So remember, 2 tumors. You finish your story of breast cancer, take a deep breath, understand first, these are the mistakes you should not make. That if you see bilateral breast masses, you see discohesive infiltrates, and if you see that the cells are going around lobules rather than destroying them, that's the first clue that this may not be a primary breast cancer. And if you see apoptotic debris, or if you see accompanying myeloid cells, think of hematolymphoid malignancies. And it's the same morphology, anything odd in breast, okay, signet ring cells, bilateral, please rule out metastasis from other primary tumors. Now, a little bit about malignant mesenchymal tumors before I wrap up. Remember, remember I told you epithelial mesenchymal transition. So the first thing in any malignant lesion tumor is first rule out a metaplastic carcinoma. Okay. The second thing is, then yes, if you've ruled out a metaplastic carcinoma, then you can have vascular tumor, lipomatous tumor, matrix producing tumors, and any kind of sarcoma that occur in there, because breast is a modified soft tissue. So remember, core biopsy, there's a problem, because if I take this core biopsy like this, so suppose this is a metaplastic carcinoma. It has a malignant spindle cell component and it is a carcinoma component. If my needle goes into the carcinoma, I'll call it carcinoma. If my needle goes into the sarcoma, I will call it sarcoma. And the whole management changes. And if it's a pure sarcoma, of course, I'll get a sarcoma. In a malignant phylloid tumor, what happens is a large part of the tumor is a sarcoma and very few has this epithelium. So if my needle goes and finds the epithelium, then yes, I will call it malignant phylloid tumor. But if it goes into the spindle cell, I will. So in a core biopsy, if I say a high-grade spindle cell tumor, we always ask for more information. And because we know that if I have a very large mass and if it's a metaplastic carcinoma, we need to give chemotherapy. Whereas if it's phylloids, then I have to upfront operate. Even for a sarcoma, you need chemotherapy. So these are very important questions that are to be answered before I go ahead. So let's look at some couple of cases. This is a 57-year-old male with a female with a very hard lance in the brain. Now, this was called as a sarcoma elsewhere. It was actually called as fibromatosis. Now, it's not fibromatosis because it shows you mitosis and it's very atypical. It's a breast mass, so the commonest you do cytokeratin, and you see the cytokeratin is nicely positive, more in some areas than other. It can show you CD34 also, so you have to be very careful with these lesions. And this is actually a low-grade fibromatosis like carcinoma, which is a variant of metaplastic carcinoma, but it's a better behaving variant. It has high propensity for local recurrence, but lymph node and distant metastases are rare, and they do not share anything with metaplastic carcinoma, but because they are spindle-shaped metaplastic carcinomas, we call them as metaplastic carcinomas. Remember, CK expression in spindle cell tumor does not mean it's carcinoma. Remember, phylloids, especially in recurrent setting, can show you cytokeratin expression. So please see the clinical history before jumping and calling that a metaplastic. Another 74-year-old lady with core biopsy. Now, this was a mass was 9.3 centimeter. Okay, and it was very important that we say that this is a sarcoma or a carcinoma. Okay, so it was a spindle cell lesion, and you can see A1, A3 was negative. It was a malignant spindle cell A1. So we called it we said that there was a long-standing history. So we said, okay, maybe 1 year. So they said, okay, maybe phylloids, but we don't know what it is. So because we said we want upfront excision, they did excise it, and lo and behold, there were 2 components. There was this high-grade sarcoma and there was this carcinoma. And when you did A1, A3, the carcinoma stood up. So this was actually an invasive metaplastic carcinoma. If we had called them, if this was picked up earlier, this patient would have got chemotherapy, but unfortunately, that's the trick with the core biopsy. So in our review of malignant spindle cell tumors on core biopsy, this is a very small snapshot. Most of them turn out to be malignant phylloid tumor, but you do have some cases of metaplastic and high-grade sarcomas as well. So remember, always ask for radiology review and check with the past history. Now, this is a 42-year-old lady with a rapidly growing mass. Okay. And you see that again looking very spindly because now we are in the middle mesenchymal part of the story. What do you see here? Anybody? No? You see anastomotic vascular spaces with debris and you see RBCs. So we are thinking of vascular tumor here. We put articular markers, ERG, CD31 are positive. So you call it an angiosarcoma. And remember, ERG is a more sensitive marker and CD31 may be negative in some kind of thing. Now, in breast angiosarcomas, there are two variants. One is primary angiosarcomas, which occur in younger women, very bad behaving, and they are fatal. The post-radiation, because radiation predisposes to soft tissue sarcoma, those are called as Stevens-Travis syndrome. They are in older patients, and they typically show you discordance between architectural and nuclear grade. That means they'll be very well differentiated, but nuclear grade will be very high. And c-MYC is usually seen in this tumor, and lots of H3K27 is seen in these tumors. And that is why these have a better prognosis than the primary angiosarcomas. And of course, treatment is a nightmare because most of these angiosarcomas are treated with radiation and surgery, but they die very fast. The secondary ones tend to have a little better behavior, and we'll look at some of these later. One last case, 36-year-old woman with a breast mass. When we look on the higher part, what you see is a very weird, like you see very good dense collagen, and you start seeing these clear looking cells. Just to show you this. So very extremely sclerosing tumor, nothing like what any breast tumor looks like. So what you do is you pass it on to your soft tissue colleague because you've done all the bed, you've given everything. So you send it over to them and they do this marker, which is beta-catenin. And this is actually a sclerosing epithelioid fibrosarcoma of breast. And this is the EWSR mutation. Another case, now this looks like a, what do you call it? Like an egg in the breast. It's a calcified mass in the breast. They excise it, and what you see is just osteoid. You see pure damn osteoid, and you see it's an osteosarcoma like lesion. No epithelium. Osteosarcoma can be a part of metaplastic carcinoma, it can be part of phyllodes tumor. You don't see anything, so you call it estrogenic sarcoma of breast. This is the SAT-B2. Now there is a huge problem because WHO, says that who are you? We are we. So you call all OGS as metaplastic carcinoma, but that's the dilemma because metaplastic OGS are mixed of tumors, and this is actually there are more cases, but I just took a snapshot of 5 cases, and you say some behave so well and some are aggressive. So to me, the ones that are behaving well are actually the true metaplastic carcinomas, and the ones that are dying rapidly are the primary osteogenic sarcomas of the breast. So just to conclude that malignant lesions of the breast have a wide spectrum, and you should understand this, and you should understand how they will be treated, especially the mesenchymal ones because they are fraught with issues. And I think awareness is the first step to reducing errors in patient management. And as I'm talking, the wheel of time is turning and some new entities are adding, and that's breast pathology for you. And I'll be happy to take any questions, but we'll finish the cases and then we can maybe start with the other things. Let me go to can you see my PPT?
Yeah, madam can see, but it is not in the PPT format. Now we can see. Yes.
Okay. So the first case is a 65-year-old lady. Karvita, I need you on all these cases.
Yeah, I'm here.
Thank you for bearing with me for 1 hour.
No problem, ma'am. It was a pleasure hearing you.
So 65-year-old lady with nipple discharge, non-healing ulcers in the right nipple. Now she came with 2 biopsies that were negative. So she came in 2021 with us, and we always do mammography for all our breast cancer patients. And she had coarse heterogeneous calcification and she had thickening of the left-sided nipple. Then she had a mammography, MRI done, and there were some retroareolar lesions, and these are the sizes, and a nipple biopsy was done, and that nipple biopsy we call Paget's disease. So they did BCS with nipple excision, and grossly nipple was ulcerated, and there was a 2.56 centimeter nodularity that was sampled. So I need the resident's name. So right, just give me time. Since you all are not volunteer for cases, I'll have to pick one of you. Okay, so you can see this is so. Swara, do you want to go first and just describe what you see? This is a nipple biopsy. So you see there is skin. Anything wrong with the skin? You see these cells, right? You already have a diagnosis on the. So you see the squamous epithelium is infiltrated by these large cells, right? Children, anybody else also is okay. If Swara is not comfortable, I'm okay with others. No? Okay, anyway. So this is Paget's disease of the nipple. You can see that there are cells within the epidermis and it's ulcerated epidermis. So the most important thing is to look at what is down below that is spreading to the nipple. And lo and behold, that's the mass that we had. Okay, that's the mass that we had. All sections from the mass that was 2 centimeter odd. And now what do you see? Now this you have to describe from me. So invasive or in situ?
Ma'am, invasive.
Invasive.
Invasive. Okay. What if I tell you it's in situ? Because you see here there is DCIS, right? These are all DCIS. Right? So actually what you're seeing here, Swara, it's Swara, right? I'm sorry, I can't see your live feed.
Yes,
Yeah.
ma'am.
So what actually you see is that these are, so what has happened is this is a main duct. From that, again, my laser pointer you want, right? Okay, let me go back to the, no, I don't have to stop sharing. Go full screen and look for the pointer options. So you see what basically has happening is that this is one TDLU or one lobule of breast. And the DCIS has now spread into the lobule. So small lobules, can you see here? So it's spreading there. Okay. And what you're seeing on the right side is nothing but one lobule that is occupied. But yes, there are areas where you're very uncomfortable that there's something coming out of that lobule also. And there is dense inflammatory response. So this makes you worry, 100% agree. Anybody has any other diagnosis? Anybody? You'll have seen the cases, right? Or you didn't? Okay, let's move on to the next one. Again, the same thing. You have very dense inflammatory response around the ducts. You have these little nests coming out. You see this little nests, you're worried that what is this? Is this lobular cancerization and it's going into very tiny lobules? Or is this invasion? So what will you do next? Now,
IHC.
Marcus.
which marker, Jyoti?
Ma'am, CK756.
So here I'm looking for invasion, right? So which are the markers for invasion?
SMH.
SMH.
SMHCC and P63, right? Fantastic. Very well. Very good. So we'll do those IHC. So this is your SMHC. What do you see? It's missing in some of the ducts, and you can see those nests that are out are totally devoid of any myepithelial markers. You see that?
Yes, ma'am.
And here also the P63 is missing. So those are the foci of invasion. So you will, because they're small, you call them as microinvasive carcinoma. We'd also do a HER2 because most of these high-grade DCIs are HER2 positive. And you can very, at a scanner level, see that it's beautiful HER2. And you see all these areas coming out. Those are the ones that you're worried about are invasive. Okay. So the summary is that this is a DCI spanning 2 centimeter. It has 4 to 5 foci of invasion. It's HER2 positive. So to my residents, do you exercise any specific precautions when you're, suppose I have a diagnosis of suspected Paget's disease or DCIS on a core biopsy, how will you gross this specimen?
Ma'am, the entire nipple areola complex should be submitted, and along with its perpendicular sections should be submitted for Paget's.
Correct. That's for Paget's diagnosis. But what about the rest of the breast? Because also important, Garvin needs to know whether there's invasion down below. And if you see that we've got invasive foci in our DCIS, right? So
We need to paint the margins.
Ma'am,
no, so, yeah,
extensive mastectomy should be done, ma'am.
No. So when you gross, remember, we grid the tumor. That means, what do you mean by gridding? That means if this is my face of tumor, then I totally slice the tumor from end to end so that I suppose this is microinvasive, but if I don't do this end-to-end sectioning of the tumor, and if there's an invasive, frankly invasive tumor that I missed, then we will totally miss a HER2 positive invasive breast cancer and the patient will have metastasis very soon. Okay. And DCIs, they are not going to give any adjuvant, but if you say invasion, they are going to give full adjuvant chemotherapy for this patient. So that's the precaution. And Garvit, what kind of surgery will you do for this patient? You already have one lumpectomy with nipple excision. Will you stop at that or something more?
So, Paget's disease of the nipple is one of the indications for doing an MR of the breast. If the MR is showing any other disease, any non-mass enhancement, I will go in for a mastectomy for this patient. Otherwise, a central quadrant excision with a reconstruction with a 40 flap, depending on what the breast size is.
Okay. Now, most important question: will you give a chemotherapy or not?
So with a microinvasive disease, I would, and especially if the HER2 positivity is being seen on the invasive component of the disease, I would like to give her some amount of chemotherapy, and depending on this thing, targeted therapy, definitely. Even if it is just microinvasive, she's going to get a trastuzumab, a single agent minimum. I may add a paclitaxel if I see a lot of these microinvasive foci. Then I will give a 12 cycle paclitaxel with trastuzumab and cover it up with one full year of trastuzumab as maintenance dose. Radiation therapy I will decide based on whether I've saved the breast or no, and whether the nodes are positive or no.
Correct. So the most important Garvit is trying to tell you is that if mastectomy is done, there's no need for radiation in this patient. In the BCS, you will go ahead and radiate, and any kind of lesser surgery, margins, etc., etc. Now there is a lot of normally in DCIS we don't advocate doing HER2, but this is a unique instance because this is a palpable or whatever clinically symptomatic lesion. So here we definitely do, and with that HER2 changes the whole story because the HER2 will push Garvit to give. Now whether to give 1 year of trastuzumab or only 12 PCIS is a very contentious issue, but we have to give some form of adjuvant depending on which practice are you in. So we move on to the second case. It's a 70-year-old lady with a 4 centimeter palpable mass. The mammography is clearly malignant. Now, this is a very unique radiology. What you see is a lobulated mass with varying amount of intensities. You can see sometimes it's actually you have pouches of different intensity. And this is the unique appearance of a mucinous carcinoma of breast on mammography. And this is what you get. Now, who's the next in line? So would you like to describe, Monica, Pratyusha, would you like to describe this tumor? No? Do you see mucin?
Epithelial tumors, nascent cords arranged in desmoplastic stroma, man.
This is not desmoplastic, this is mucin, child, because I told you, even on radiology, it had mucin, right?
Yes.
So one important thing to do is that means you've not listened to my pattern. But this is a trick question. So you see, this is reverse polarity. Okay, this is a micropapillary pattern. Normally, towards the cilia, can you see here the cilia? Normally the cilia are oriented inside, but here they are outside. Okay, so this is you see nicely here. Okay, this one also has. You see that little edge? The cilia are on the outside. So this is micropapillary pattern. So this is that type A type of mucinous carcinoma. You see here, nice cilia. Okay. So I will call this invasive mucinous micropapillary carcinoma. That's the diagnosis I will give. You can see here again micropapillary. And I will say that the amount of mucin is 70%. This patient had a upfront surgery. She was node negative. We do MIB1 in these cases, besides ERPR HER2. Because if it is, in breast cancer, the ERPR is divided as luminal A and luminal B. The luminal B get chemotherapy because it gives them 5% benefit of oral survival, and that's why we do MIB1. Okay. Now we move on to the third case. So this is a 42-year-old lady with a breast lump. It's a 7 by 7 centimeter lump, very frankly malignant. So anybody wants to describe this? Oh, Monica?
Ma'am, it looks at low power, it looks poorly circumscribed tumor, infiltrative.
Correct. Perfect. Infiltrative. Perfect.
And there are solid sheets of area showing
so
vascular like
DCIS or invasive?
DCIS, ma'am.
This is DCIS. What about all this?
Invasive.
You said,
These are invasive. Yes, ma'am.
Correct. So there's invasive process. So you have invasive carcinoma with DCIS. Perfect. Now, do you want to grade it? Is it a higher power? No, sorry. You want to grade it. So we grade it based on modified RB score, which is tubule formation. Do you see tubule formation?
No, ma'am.
No, there is no tubule. So it's 3
Yes,
for tubule. Nuclear grade, I'm
yes.
sorry, I give you a higher patient. I'll have to say that because there's comedonecrosis, this is high grade, so it's 3. And there is the next one. I should have given you a higher power, but I haven't given you that. So that's okay, sorry. So DCIS and LVR, some of the things that we mentioned on a code, because something called as HDR is done, or a high density radiation or brachytherapy is done for operable breast cancers. And for that, we need to know. Now, this is the ER. What would you grade this ER like? So
Positive.
we use a
Positive. 8 by
correct.
8, ma'am.
Absolutely perfect. Do you want to give an all score details here? Anything,
8
whatever.
by 8.
Correct. 8 by 8, yes, but 8, so 80 or 90% strong, right? That's how we give the scoring for the ER.
Yeah.
The PR. Anybody for the PR? Ankit is not here. I'm not sure whether he's here. Ankit, Shruti. So how much percentage of ER cells is positive? 50%?
Yes, ma'am. Less than 50 only.
Yes, 40. So 40, anything above 30, right? So it's
Yes, ma'am.
so it's not the last grade. So it's not 60 above, 66 and above. It's between 30 to 60. So that will be 4 for the percentage of cells and 3 for the intensity. So this will be 7 by 8. Is that okay?
Yes, ma'am.
Yes, ma'am.
What do you call the HER2?
Weakly positive, ma'am. 1 plus or 2
I'm
plus.
sorry, I didn't go higher. Yeah, but you see, this is the 20x trick. That on 20x, if you don't see a HER2, then you're not likely to get it positive. So this is mostly 1 plus HER2 or an ultra low HER2. Okay, which is basically any equivocal non-amplified or anything that is greater than 1%. Now we use this because we use antibody drug conjugates. What are these? These are HER2 trastuzumab tagged to a cytotoxic drug. The role of trastuzumab is only to take the drug, the cytotoxic drug within the cell and kill it. So you don't need high amounts of trastuzumab. You need just a little above normal, and that's what is low HER2 today for you. So this is the core biopsy. So what are the guidelines we finished and any other factors? Okay. Garvit, so what will be on this core? What will be your treatment for this patient? This was the story. So you had a 7 centimeter lump with a 2 centimeter hard mass in the axilla. So this is a locally advanced breast cancer. So what
I
will
would
be your
be, although this is 8 plus, 7 plus, I am still going to try a chemotherapy regime and see whether if it shrinks or no, because locally advanced, I would want to see with chemotherapy if it works. If it doesn't, surgery. Anyways, if I get a response after 4 cycles, I will offer her surgery. I will be more likely to offer her a mastectomy than a breast conservation surgery.
Okay. Okay. Any reason? Because it's 7 centimeter.
7 centimeters. I want to see the response, and I'm more or less certain the response is not going to be more than 50% with an 8 plus 7 plus ERPR and her to no ultra low. If I'm with a PDO setting, anyways, PDO will not be able to be at 42. I'm not expecting the PDO to completely disappear. It won't go.
Absolutely. Absolutely.
Madam, one question on the previous this thing. Can I ask?
Which one?
The
This one?
mucinous micropapillary, slightly
Correct.
off the this thing. Do you do AR on mucinous micropapillary or no?
That is research thing. So I'll tell you the full story. I can't tell you my trump card. No. So
Okay,
private conversation, not in a recorded meeting.
I'll do it tomorrow.
So this is Mamta's thesis topic that we are looking at different hormones, etc. So I'll tell you because we want to publish it first and then we'll talk about it.
Okay, ma'am.
Thank you so much. And sorry for not answering it.
No issues, ma'am.
So, okay. So now we come to the last case, which is a 48-year-old lady with rapidly growing mass with skin ulceration, incision biopsy done. Now the last two, Sonal, right? Yeah. Shruti, Sonal, anybody can take it up. What do you see? So this is the ulceration, okay? The one that is, this is all ulcer and this is your tumor. You want higher part of the tumor? That's the higher part. Spindle, carcinoma, anything else? It does look spindle, right?
Yes.
and there are some eosinophils, right? You have to ignore, because sometimes life, remember, it distracts you from what it is. Okay, so you say spindle cell. So I told you one thing, the first marker to do in any spindle cell tumor is what?
This one.
CD.
First marker, because you know that first
CK.
important thing. Correct, perfectly. So you do CK. Your CK is negative, then what will you do?
CD31.
Perfect. Okay, because that's your algorithm. And after this, you can do any markers or sign it, give it off to a soft tissue pathologist. So that's the CK, which is negative, and this is CD31, which is brilliantly positive. So this is an angiosarcoma of breast. Okay. Now this is solid spindle cell, little odd variant, not where there's a very good vascularity. So Garvit, what is your management now? This is an ulcerated skin lesion.
So, and age of the patient?
Around 45.
And previous history?
Nothing. No, not radiation indices.
So this is a primary angiosarcoma.
Yes. Yes.
First and foremost, I'm going to counsel her that the prognosis is not going to be great for this.
Correct.
It is going to be a wide excision in terms of it is going to be a mastectomy. I am also going to, although there are very less chances of anything spreading to the lymph nodes, I'm going to sample the lymph nodes. If they're positive, I clear. Very rarely we do find, even with sarcomas,
1 or 2%, but by and large,
yes,
negative. Okay.
for that, all enlarged lymph nodes, I'm going to send for frozen section. If they come positive, I'll excise, but it's very unlikely that it will be positive. And followed by radiation therapy. There is very little role of chemotherapy in these cases. Mostly, it will be adramycin-based chemotherapy.
So there is some, Dr. Gupta uses this propranolol. I showed it in my PPT, but I didn't want to go into that time. So he uses beta blockers and that cyclophosphamide therapy, and that has shown a slight improvement. I'm not saying patients ultimately die, but they get at least 1 or 2, 3 years of respite before they succumb to the disease. So I think there is promise, and there's promise in bevacizumab as well, because it's a VEGF inhibitor. But nothing is concrete, and these are so rare cancers, to get a randomized trial will be almost impossible.
Any amount of data is very difficult to get on those these
Correct.
patients.
Correct. Anything else? I think that's the end of my slide show. Anybody wants any questions at this end?
Ma'am, someone is asking the last one slide, ISC slide for angiosarcoma, I think.
To repeat it, to show
Yes,
it again.
ma'am. To show it again. Yes, ma'am.
मैंने बंद कर दिया ना उसको. This is an old case, but it was a little difficult diagnosis at that point of time. That's the slide.
Yes,
Do you
ma'am.
want what they would not? So this is, so what happens? CD7. This was an older case. We didn't have ERG that time, so we did 31. It shows you membrane staining of the cells. Okay, you can see the internal control of vessel, which is positive. Anything else you want to ask? Anybody wants to ask?
No, ma'am.
No? So shop sharing? Okay. Any other questions in the chat box or anything? I don't know how this works.
Ma'am, not till yet.
Garvit, anything for me you want to ask?
I already asked my question, ma'am. We'll discuss that later.
That one is very interesting.
But this was again a very good session for me also. I attended the full 1.5 hour. It was remembering the teaching days, as in student days for me, teaching days for you.
गर्वित तू तो मेरा बॉस बन गया है.
मैडम छोड़ो अभी, बाद में बात करते हैं.
Sir, you can please give some take-home message for a student regarding this crossing and the histopathology reporting. What you like, what you expect from PG from the pathologist, like.
So, thank you for asking that. A lot of times, I think this is part of our training that we, especially when we can, we try and be part of the grossing. But there are a few things that we want very clear information on, especially in malignant lesions of the breast. One of them is obviously the grade and ERPR, IHC, Key 67, MIB1 index, all that you will give me. What I want clarity on is margins of the tumor and how you're sampling the margin, like what madam told you about gridding the sample properly. A lot of times it's very difficult for us to understand. When you say that margin is focally positive, I have to go back and check, and I go back and see with the pathologist what margin are you talking about, how was the margin taken. So that is an absolute clarity we want the margin to be discussed. Whether it is DCIS, that's a different clarity that I want. And with a malignant tumor, I want a different clarity, in the sense no ink on tumor on malignant tumor, on an invasive tumor, and at least a 2 millimeter distance between the ink and the tumor surface in DCIS. Why we want that kind of margin, I think madam will be able to explain it better, and she did tell us, there can be skip lesions and there can be two ducts. If ADH is involving more than two ducts, we also take, there is another definition of 2 millimeter or more, or the percentage of the duct being involved when it is called DCIS. So we do, margin is one thing that we are absolutely this thing on. We also would like to know other prognostic factors like LVE, lymphovenous embolization, or PNI status, because these things add up to our decision making on whether to offer cytotoxic therapy to the patient or not offer cytotoxic therapies to the patient. When you're reporting on the lymph nodes, it is important that you tell us what is the size of the met. Because if it is less than 2 millimeter, I'm not going to react to it in a clinical sense of the way. Like, I'm not going to ask her to do a repeat surgery or anything. But if you just tell me sentinel lymph node positive or a single node positive, I would have to, pick up the phone, call back again and ask what is the size of the met. Then please do report on extranodal extension, because that's again a very important prognostic factor. Even if the size of the tumor is very small, as in size of the met is very small, but if I find ENE, I'm going to react differently to it as compared to when it is within the lymph node and it is just less than 2 millimeter, a micrometastatic disease. So these are few things that off on the top of my head which are coming, but we keep going back. Now, whenever we get a report of a metaplastic carcinoma, I want a complete answer on squamous or anything else, because a lot of times what happens is when, most of these tumors, and ma'am will agree with me, come back as triple negative cancers, because none of these is taking up any of these stains. And when you write triple negative breast cancer in the impression, my medical oncologist is going to just stand up and say, okay, go give chemotherapy. But in a squamous based cancer, I'm not going to ask her to take chemotherapy. I'm going to operate first and then decide. Obviously, it depends on the size of the tumor and how much of it is involved. So metaplastic is something I would want more clarity on when you're reporting it, what kind of metaplastic cancer it is. Because a lot of times, I would also want to know what is the percentage of
Absolutely
that
fantastic. I always say,
because if I don't know if it's just 1%, I'm not going to. I know rest of my tumor is going to respond to chemotherapy, so I'll give her chemotherapy.
So Trupti,
So I want to know
he
what
looked at our metaplastics, and squamous with less than 50% squamous differentiation, they did very well. Whereas anything more than 50 had very bad prognosis. I removed some of the slides because I thought I'm talking, and there sometimes maybe it's not required, but but
it has clinical implication for us,
correct,
because
correct.
we decide whether this tumor is going to really. If it is more than 50%, I know this is not going to respond to chemotherapy, no matter what you do. Might as well take it out as soon as possible.
Correct.
But if you write triple negative breast cancer without specifying it's a metaplastic breast cancer, and the patient goes to a medical oncologist who's not, who on a knee-jerk reflex is going to say, "Acha, chemotherapy because it is TNBC," which has happened a lot of times, where the patient has seen me after 2 cycles and I thought, boss, this is not going to respond. Let's operate and we'll see whatever chemotherapy we can give you later. So this is important. These things are important, especially in your impression. If you have a special type, mention it. For all that, this thing would be, and this is for the students also, the maximum you will do is probably you will go wrong in subtyping it. You will not say wrong cancer. You will probably wrongly subtype it. We'll get it seen by a senior and we'll make confirm. And that ways we will the doctor who's the clinician who's seeing the report will have something in his mind or her mind to be before with a knee-jerk reaction starting on therapy. We'll have to at least, if the person does not know of that subtype, is going to read about that subtype and then treat the patient. So if you have a subtype in your mind and if you've done your stains and if that is showing, please write it in your impression. If you're not writing it in that impression, we are presuming a lot of times people don't even read what is been written in description. It's a bad habit, but some people don't, and they just see the impression. And just imagine triple negative breast cancer and person going for chemotherapy where chemotherapy was not going to be of any benefit. So few things that came to my mind right now.
Thank you so much. Thank you so
Thank you
much.
so much, sir. Sir, one question in the chat box. Could you please explain regarding the angiosarcoma treatment again?
So angiosarcoma treatment, angiosarcoma is one of angiosarcoma of breast or angiosarcoma in general is a very difficult tumor to be treated. Most of this the therapeutic modalities that we use are local because we don't know much about this tumor. We end up excising the tumor with wide margins or a lot of time just doing a mastectomy. This data is coming from sarcoma of other body parts where we do less conservation surgeries. We remove the organs, we remove the limbs based on when it is diagnosed as sarcoma. The radiation therapy is another. So, like I said, only local therapies have shown some benefit. The systemic therapies have very less promise in them. They're like any chemotherapy, if we give for sarcomas, they generally don't respond very well, and we end up losing the patient. No, we lose the patient any which ways. Angiosarcoma is not a good diagnosis. Primary angiosarcoma specifically. Secondary angiosarcoma, which has been diagnosed, which has the cause is radiation therapy, like post-radiation angiosarcoma, they generally tend to do a little better as compared to primary angiosarcoma. The treatment remains the same. It is more local treatment, excise the tumor completely with margins or mastectomy in most cases, and sample the axilla, because a lot of time, because there is ulceration associated with angiosarcoma, there will be nodes which are enlarged. So we do send those enlarged nodes for frozen section, but like madam said, only 1% of them they will have metastasis in the nodes. And post the surgery, we offer them radiation therapy, and we hope that we win and the cancer does not, but most of the time we lose.
Thank you, sir.
Is there anything else?
Ma'am, not in everything is covered, ma'am. Not in the chat box. No question in the chat box.
Okay. If there are any questions, you can direct to me. I'll be happy to answer on email as well. And nice meeting you, Garvit. So I guess this is thank you. Sumit chala gaya lagta hai.
I don't think so.
Impress doesn't impress Sumit. Chalo.